Assalamu alaikum. Good evening, everybody. I am very delighted tonight, on behalf of the MENA International Diabetes Federation, to welcome all of you in the webinar under the title of Prevention of Diabetes Mellitus. Diabetes experts and seniors will be speaking on this event. The duration of each presentation is 25 minutes. All the questions will be answered by the lecturers at the end of the webinar in 20 minutes. So now I would like to introduce my friend, Professor Adil Sayed. He is consultant of diabetes and endocrinology, Faculty of Medicine, consultant of the WHO, and president of the Egyptian Alliance for the Incommunicable Disease, ex-IDF MENA chair. The title of the lecture, Pre-Diabetes, the Unrecognized Problem. Professor Adil, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much. I'm very grateful to Dr. Jamal, Dr. Sandeep, Dr. Mohammed Hassanein for kindly and for organizing this series of webinars. My topic today is pre-diabetes, which I believe should be the introduction for the issue of diabetes prevention. I prefer to put it like unrecognized problem. Actually, it is less recognized than it should be. And let me start first with definition of pre-diabetes. Impaired fasting glucose, we all know, normally it's the fasting blood glucose is less than 100, but if it is 100 to 125, this is an impaired fasting glucose. Impaired glucose tolerance between 140 to 199 milligram per deciliter. Together, these two items are called pre-diabetes, but hemoglobin A1C can be added if it is between 5.8 to 6.4. These are the items which define what pre-diabetes is. Now, I did the definition of pre-diabetes. Now, I would like to proceed to present the importance of pre-diabetes, which is my agenda, actually. It's because, well, pre-diabetes is important because of the high risk of progression to diabetes, because it is the reservoir where diabetes comes from, actually. So diabetes prevention will usually on the cohort of pre-diabetic individuals, because pre-diabetes per se, without progression to diabetes, has macro and microvascular complications, and this is a very important issue, and because it is asymptomatic. So its treatment as well, its treatment is effective, but we have challenges regarding the treatment of pre-diabetes. Now, let me touch very, very quickly every one of these items. Number one, high risk of progression to diabetes. There are estimates that we don't have actually very accurate figures, but the current estimates indicate that most individuals, maybe 70% of people with pre-diabetes will eventually progress to be frank diabetes. And the transition from impaired fasting glucose or impaired glucose tolerance, usually it takes years to become diabetes. And we now know that the initial level of hemoglobin A1C is very effective in estimating the risk of progression to diabetes. You can see now that between 6, if we are on the high side of the pre-diabetes, between 6 and 6.5, if the hemoglobin A1C of an individual is between 6 and 6.5, the chance of developing diabetes in the next 5 years is 20 times for that with a hemoglobin A1C less than 5. So the higher the hemoglobin A1C, the initial hemoglobin A1C, the more the risk is to will be to develop diabetes during the coming through few years. Diabetes prevention. I won't go through diabetes prevention in details because I know other speakers will speak about that in details. But the questions, there are two questions here, two important questions here. Can treatment of prediabetes prevent the progress to diabetes? And the second question is, treatment of diabetes and diabetes prevention, this will come. Actually, the treatment of prediabetes is diabetes prevention. I mean, if we are dealing with, from the angle of point of diabetes, we can call it diabetes prevention, and we can call it diabetes prevention. We prevent diabetes by treating prediabetes. This is what I'd like to say. Then let me just touch very quickly the diabetes prevention program. Well, it was published almost 20 years now, and included more than 3,000 non-diabetic individuals, and they are divided into 3 arms: lifestyle modification, intensive lifestyle modification with a target of 77% weight reduction, and metformin therapy with a dose of 850 twice daily, and placebo. Placebo means giving ordinary advice without any stressing, without any programs for the patients. And these are the final results of the diabetes prevention program. You can see now that with intensive lifestyle modification, we can reduce 58%. So every 100 patients develop diabetes from the placebo group, we have only 42 patients develop diabetes in the lifestyle group, and we have 69 patients can develop diabetes from the metformin group. So the lifestyle modification is the best, followed by metformin, and then for those with placebo. So that trial and the other trials of diabetes prevention left us with an unequivocal fact that type 2 diabetes is a preventable disease, and that had been a very important discovery in the field of diabetes. Now let's have a look to the vascular complications of prediabetes. Now I'm speaking about diabetic and pre-diabetic individuals who have not yet proceeded to be diabetics. It's just prediabetes per se. Those patients can develop macro and microvascular complications, and the questions here will be, is prediabetes associated with increased vascular complications, especially cardiovascular risk? This is the first question we would like to answer. And the second question is very important. Is treatment of prediabetes associated with improvement in these vascular risk? These are not the same question. These are two different questions. You might be able to prevent, I mean, the disease might be, prediabetes might be associated with increased vascular risk, but when we treat it, the vascular risk will not decrease. So the two questions are not automatically answer each other. So let's have the first question. Is prediabetes associated with increased vascular risk? We have actually micro and macrovascular complications. If we look to the microvascular complications, you can see here the nephropathy from normoglycemia, euglycemia, to fasting blood glucose, to fasting impaired fasting glucose and impaired glucose tolerance. And you can see the progress throughout these 3 conditions, illustrating very clearly that with impaired fasting glucose and impaired glucose tolerance, nephropathy increases gradually. And this is for neuropathy. The same thing happens, but maybe the increase is not as severe or as high as nephropathy. And here, the retinopathy. The retinopathy has something peculiar because it sharply increases when hemoglobin A1C is more than 5.5 compared to hemoglobin A1C less than that. And individuals with impaired glucose tolerance have approximate 10% incidence of diabetic retinopathy. And this is a very high rate, actually, and I'll come to that issue in a moment now. Now, the macrovascular complications, and especially the cardiovascular risk. Pre-diabetics like overt type 2 diabetes is accompanied with higher cardiovascular risk. And that's why those patients should be aggressively treated for all risk factors. Now, these are the cardiovascular endpoints we used to use: all-cause mortality, compound cardiovascular events, and coronary heart disease and stroke. You can see for every one of the cardiovascular endpoints that people with prediabetes are in excess of these endpoints compared to those with euglycemia. You can see that the amplitude, the difference between the risk here are not very high, but there is a definite risk, and in many of them it is statistically significant. Now let's have a look to some trials illustrating that. As early as 1990, which is 30 years old now, this trial, with the title of "Does the Clock of Coronary Heart Disease Start Ticking Before the Onset of Clinical Diabetes?" And here, pre-diabetic individuals, this is the assumption of the study. Pre-diabetic individuals might have an atherogenic pattern of risk factors even before the onset of clinical diabetes. And they recruited more than 600 initially non-diabetic persons who participated in an 8-year follow-up of San Antonio Heart Study. This is a very famous old cardiovascular complication study. So they recruited a number of those patients who were non-diabetics, but they progressed to diabetes during the 8-year period of follow-up. And these are the results. The results of this study indicated that pre-diabetic subjects, the pre-diabetes here were defined not on terms of hyperglycemia, but on terms of those who progressed to diabetes. They found that those patients who progressed to diabetes had an atherogenic pattern of risk factors: higher total cholesterol, LDL, triglycerides, fasting glucose, insulin, 2-hour postprandial glucose, body mass index, blood pressure, and lower levels of HDL. So the risk factors in those patients who progressed to diabetes were much higher than those who did not proceed to diabetes. This is another study, which is the Euro Heart Survey on Diabetes, published in the European Heart Journal in the year 2004. They estimated the risk of being pre-diabetic or diabetic in patients who develop ischemic heart disease. And they found that 20 to 30% of patients with coronary heart disease who presented with newly detected glucose intolerance or diabetes. They were not known to be diabetics or pre-diabetics before, but they were found for the first time when they present with ischemic heart disease. 20 to 30%, almost 1/4 of them, showed diabetes or pre-diabetes. And in case of myocardial infarction, they found that 70% of patients who presented with myocardial infarction without any previous diagnosis of diabetes, 70% of those patients were found to be either diabetic or pre-diabetic. This is the third trial I would like just to shed some light on, the EuroAspire. It's a huge sort of program which is currently running in Europe now. It's studying the compliance of European countries with the Joint European Society Prevention Guidelines? Well, it's a big trial. I won't go through the whole trial, but in the arm, it have 5 arms actually. The arm 4, it's a cross-sectional survey of more than 4,000 patients who with no reported history of diabetes, but with their fasting plasma glucose and 2-hour plasma glucose and hemoglobin A1C was measured at the start of the study. I'll stop here regarding the study just to show you this. These patients were diagnosed as diabetes or pre-diabetes according to different methods, one of the WHO and one of the ADA. This is not important for me now, but what's important here is that blue part of the circle here. You can see that between 1/2, it's 45% actually, to 2/3 of the patients who developed ischemic heart disease were pre-diabetes, and the definition here of pre-diabetes is our definition. It's hyperglycemia short of becoming diabetes. So these 3 trials illustrate the history, actually the progress of clarifying the relationship between pre-diabetes and ischemic heart disease. But this relationship, which is very clear now, is not a causal relationship. These trials did not prove a causal relationship between pre-diabetes and ischemic heart disease. But when treatment of pre-diabetes will decrease the risk of ischemic heart disease, that will show a causal relationship. And this is the second question. Is treatment of pre-diabetes associated with reduction of cardiovascular risk or not? Yes. In the Stop-Needham trial, this was published in the Diabetes Care in the year 1998, showed that acarbose, in this trial, they used acarbose to prevent diabetes or to treat pre-diabetes. And that trial showed that use of acarbose in pre-diabetics was associated with significant reduction in cardiovascular endpoints. So in this trial, treatment of pre-diabetes by acarbose was accompanied with reduction of cardiovascular risk. And the second study is a meta-analysis published in the New England Journal of Medicine in the year 2002. They demonstrated that in both changes on lifestyle, treatment by lifestyle change, and administration of metformin, these are the 2 items used in the diabetes prevention program. They can prevent diabetes, and meanwhile, they can significantly reduce cardiovascular death, ischemic heart disease, and stroke. So in this paper, these 2 studies, it is clear now that the relationship between pre-diabetes and ischemic heart disease is a direct causal relationship. It's not just a sort of association. Now, the clinical implication, what are the clinical implications of these trials? The clinical implications is the fact that cardiovascular disease appears early in the course of glucose metabolism abnormalities, even before becoming diabetics. And this requires earliest diagnosis. We have to diagnose people with pre-diabetes, and this is why pre-diabetes is important. We have to diagnose it before progression to diabetes, and we have to follow a preventive strategy in those people with pre-diabetes with aggressive action against all the risk factors of vascular disease, especially those associated with increased atherosclerotic cardiovascular disease. We have to treat hypertension, dyslipidemia, sedentary life, obesity. All the risk factors must be aggressively treated, smoking cessation, and all these items have to be aggressively treated in patients with pre-diabetes, just similar to that of diabetes. Now, this is the final part of my presentation. The challenges we have in dealing. Now we know that pre-diabetes is very important because it gives us those patients with diabetes, and because it is per se, without progression to diabetes, is dangerous and risky to develop diabetic complications. Now we have some challenges actually regarding dealing with pre-diabetes. These challenges are summarized in diagnosis of pre-diabetes. We have challenges here, and we have challenges in the issue of pre-diabetes versus diabetes, and I will come to that in just a second. Diagnosis of pre-diabetes. What are the challenges to diagnose pre-diabetes? Number one, it is an asymptomatic condition. Pre-diabetes is asymptomatic. No symptoms whatsoever will accompany a patient with pre-diabetes. That's why we have to go for screening. We don't wait for those patients to come to our clinics complaining because they are asymptomatic. So we have to go for screening, and you know how difficult and how challenging the issue of screening is, because I have nothing. Why are coming and just breaking my finger and taking blood and wasting my time? So this is a very big challenge regarding the diagnosis of pre-diabetes. Another challenge, important challenge, is the tool used. We used to diagnose diabetes using glucometers. These tiny, small sets everybody is having in his clinic and in his home, measuring blood glucose. We are very satisfactorily diagnose diabetes using these glucometers. But remember that here we have a gap between normal and diabetes. Fasting, it's 26 milligrams glucose between less than 100 and more than 126. And in dealing with postprandial impaired glucose tolerance, we are dealing with a more marked difference between less than 140 and more than 200. So these glucometers are satisfactory in diagnosing that. But when the difference is very subtle, when I would like to differentiate a patient who has a fasting blood glucose of 98, for example, from that of 103 or 104, will these glucometers be sufficient or not? And how to behave, what to do? We don't have recommendations actually regarding that. We have very clear recommendations in diagnosis of diabetes. We have to have 2 readings in 2 different days above the cutoff value. But in pre-diabetes, we do not have recommendations, either that or we can have 1 reading with classic symptoms of diabetes. But for pre-diabetes, we do not have the tools. We do not have exactly what to do regarding the tools. And we do not exactly have recommendations what to do. So we have to work on that point if we would like to diagnose pre-diabetes. So in diagnosis of pre-diabetes, it is asymptomatic. It requires us to screen people, and that we are not sure about the tools we are using to very accurately measure the blood glucose level. And at last, we have to develop recommendations for diagnosis. These are some challenges we are facing regarding diagnosis of diabetes. The other issue is interesting: pre-diabetes versus diabetes. I don't know if you can remember. Well, those who are not old enough must have the knowledge, at least if they cannot remember, that we changed the cutoff level of blood glucose level and in diagnosis of diabetes in the year 1998. And before the year 1998, the fasting blood glucose diagnostic level was 150 milligrams per deciliter. And during that year, there had been 3 big trials. One of them was done here in Egypt, by the way, which proved unequivocally that patients before that level, before fasting 140, they can develop retinal complications. So because of these trials, the cutoff level decreased when they plot the appearance of retinal complications and the level of blood glucose. They found it 126. They found in these trials that it is the cutoff level is 126 and not 140, and they changed that. Now we have proof of cardiovascular complications of prediabetes, and we have proof of microvascular complications of prediabetes, and we did not do the same thing. Why? Why didn't we call all those patients as diabetic and just, be comfortable regarding that? All of them are diabetics, and that's it. Go ahead and treat them. Why we are still dividing them into diabetes and prediabetes, in spite of the fact that we know for sure now that both of them will develop the same complications? Where is the point? What's the point of dividing them into diabetes and prediabetes? This is the dilemma. Why we are still diagnosing prediabetes? Maybe because the magnitude of the risk is not high enough. Definitely there are risks, as we have shown, as we have seen now, in both microvascular and macrovascular, but the amplitude, the magnitude of the risk is not that high. That might be one item. And the second is because of the stigma. We stigmatize, if we put both of them in the same basket and call them diabetes, we stigmatize a very large number of people as having diabetes, and then starting, visiting physicians and doing things. So this stigma might be a barrier regarding putting both cases together and calling them diabetes. The last point, of course, is the cost. The cost here is a very important item. What will be the cost of following that number and put it on top of the already diagnosed number being diabetes, which is increasing very, very, very quickly? What will be the cost if we add pre-diabetics as well and start filing them and following them? And these are some challenges we are facing now regarding even the definition of pre-diabetes and the discrimination between diabetes and pre-diabetes. So in conclusion, ladies and gentlemen, pre-diabetes is an important disorder which does not receive the necessary attention it deserves. Being asymptomatic is an important part of the problem of pre-diabetes. Well, pre-diabetes is an important disorder. We now know for sure that pre-diabetes without progressing to diabetes is accompanied with microvascular and macrovascular complications. And we are sure as well that treating pre-diabetes will lead to reduction of the vascular complications of diabetes. But we have challenges regarding diagnosis of diabetes, regarding the tools and regarding the recommendations. So we have to have more work actually to standardize the way of diagnosis of pre-diabetes, and we have to educate, to increase the awareness of both the physicians and the healthcare professionals and the public. We have to increase the awareness of these two sectors about the importance of pre-diabetes, just to be able to go through and make screening and treatment of this very important condition. Thank you very much.
Thank you, Professor Adil, for this elegant presentation. Showed us the importance of pre-diabetes management in decrease of new onset diabetes type 2 and reduction of cardiovascular risk, and the importance of awareness and early detection in order to prevent this disorder. I have some questions to Professor Adil, but I will postpone until the end of the lecture. Now, I would like to call Dr. Fathiya Al-Awadi. It's my pleasure to introduce Dr. Fathiya, President of Emirate Diabetes Society, consultant endocrinology and the head of the endocrine department, Dubai Hospital. The second talk about prevalence of pre-diabetes in MENA region. Dr. Fathiya, the floor is yours.
Thank you very much, Dr. Sandeed, for the kind introduction, and Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, friends and colleagues. First of all, I would like to thank the organizer and the scientific committee for inviting me to be part of these successful virtual MENA region program over the past few months. And also, I take this opportunity to thank my colleague and friends from the MENA region who had provided me with some of the data that I'm going to share with you in this presentation. Now, as you all know that the pre-diabetes, you just heard an elegant lecture from Professor Adel Al-Sayed that the pre-diabetes is the outcome of our modern lifestyle. And as you can see here, if we move from the west of the MENA region, from Casablanca to the heart of the MENA region, Alexandria, and we move on to the east of the MENA region, Dubai, as you can see, there are massive changes that took place over the years in terms of the way that we are living. And as you can see, there are more vehicles on the road, and also we had moved to a westernized lifestyle. And all those had contributed to the increase in the prevalence of pre-diabetes as well as diabetes. Now, this is a data which is adopted from the IDF Diabetes Atlas from the 9th edition, which was recently published in December of 2019 during the Busan conference. And as you can see, there are 1 in 13 adults aged 20 to 79 years of age has an impaired glucose tolerance. And that makes 22 million more adults are at risk of developing diabetes more than 2017. Now, if we look at the prevalence of impaired glucose tolerance in adults aged 20 to 79 years of age in our MENA region, as you can see in this circle, that the prevalence of the impaired glucose is ranging between 6 to 14%. And as you can know that the IDF data usually provided by either individuals or respective countries as for the IDF Atlas, and this is based on robust research which is run in the region. But just to remind you that there is an accuracy of those data which is produced in the IDF Atlas, as you are all aware that the prevalence of pre-diabetes is increasing globally. Now, I just took 2 examples when I just searched the IDF Atlas, looking at countries, for example, like in Algeria or Jordan, and just look in the past 10 years that the prevalence of diabetes had just either decreased or remained the same, which make no sense. And that means that we are, having not an accurate data, although we are producing some of the data related to pre-diabetes, but definitely we need to work more to have an accurate data provided to the IDF Atlas. So let me now, share with you some of the data region from the Gulf study. And this is the Dubai Household Survey, which was conducted in the year 2014, 2017. Myself and Dr. Hassanin had took part as the top in the Household Survey. Now, the Dubai Household Survey was conducted by the Dubai Health Authority in collaboration with Dubai Statistics Center for the year of 2014, and it was a cross-sectional, multi-stage, certified cluster survey. The houses were visited to obtain detailed information of different healthcare issues. There are about 5,000 families were randomly selected with a response rate of 80%, and were divided into national and expat. the final sample was equal to 13,299 individuals, and 7.9% were Emiratis. Now, the design and the methodology of the survey were used in the World Bank Living Standard Measurement Survey and the World Health Organization World Health Survey. So what we have seen in this household approach to health-related behavior risk and life pattern among, as you can see here, the prevalence of physical activity among adults by age and gender was total 15%. And even in those young age group who we expect to have more physical activity, the prevalence of diabetes was, of the physical activity was low. And if we look, the gender, male to female, there was slight difference between male who's physically active, 15%, versus female, 13.8%, and there was slight difference between non-national compared to the Emiratis, which was 15% versus 13%. So that makes almost 85% of the Dubai population physically inactive. Now, if we look at the intensity and the frequency of exercise on the same household survey, we found those who had moderate intense physical activity, which is defined as 10 minutes spent doing different type of physical activity as part of daily work or as part of housework, was 17% for those who did, daily physical activity, 18% for those only from 1 to 3 days per week, and 65% who did 4 to 6 days. Now, if we look at those who did or who have been asked about the vigorous physical activities, which is defined as running or playing football for at least 10 minutes continuously, 95% of our populations who were involved in the household survey responded to this as they don't do any vigorous physical activity. Now, if I move to country, neighborhood country like Oman, and this is adopted from the Oman household survey, and if you look at the graph on your right hand of the screen, and you look at those red bars of those who did not do any physical activity, the prevalence is almost 24%, while for those insufficient physical activity, which is the yellow bar, 14%, and women were physically inactive compared to men. And if we look at the numbers of serving per day, as you are all aware, the international recommendation is to have about 5 servings of fruits or vegetable per day. They were consuming less than 5. So consequently, the physical inactivity and also less healthy diet had led to increase in the prevalence of obesity in Oman to 66%. And this is not just unique to Oman, it is applicable to the entire Gulf region as well as the MENA region. Now, if we go back to the household survey, which I already, touched upon, and we looked into into this data of the household survey, which was conducted by Dubai Health Authority and also in collaboration with Dubai Statistics Center in 2014, had identified for us those who have diabetes. So what we did, we convinced the authority in 2017 to go back to the same sample size, and we invite those who declare that they don't have diabetes to come forward and give a blood sample for HbA1c in order to address the undiagnosed diabetes and pre-diabetes within Dubai population. And we had adopted again the same design and methodology of the survey as we did in 2014, using the World Bank Living Standard Measurement Survey and the World Health Organization World Health Survey. So what we learned from this? We learned from the extension of the survey in 2017 that the prevalence of pre-diabetes in Dubai by exercise was in those people who exercise among the national, which is the blue bar, 12.4%, and among expat at the red bar, which was 16%, and they were not much different between UAE national and expat in terms of exercising or not exercising. Now, how about the prevalence of pre-diabetes by age? As you can see that the prevalence of diabetes in those with age group 18 to 35 was 10%, and it had jumped to twofold or double those age group 36 to 45, and even to threefold in those age group 46 to 60 years. That's why when we had updated our EDS consensus guideline for the management of type 2 diabetes early this year, we had lowered the cutoff of age for those who have pre-diabetes to the age of 30, because we did see we did have an evidence of pre-diabetes in this age group. Now, how about the prevalence of pre-diabetes by nationality? As you are aware, Dubai have multinational, more than 270 nationality who live in Dubai. And as you can see that the prevalence of diabetes is almost the same, and it's increasing among nationals, age group 18 to 35, and also among non-nationals. But what we noticed that those age group 46 to 60 years of age among expat was slightly higher than national, and that reflect not just genetic susceptibility, but also they are exposed to the same environmental factor like the nationals. Now, if we move, and we know that when we become heavier, then we have risk of having pre-diabetes as well as diabetes. And if you look at now, you follow the blue bars, this is among UAE, those who were normal weight, then the prevalence of pre-diabetes will jump from 9% to double, which is 18%, and the same trend is followed for the expat, which is into the red bars. And that's also reflected by the prevalence of impaired glucose tolerance by age, which is adopted from the IDF Atlas. As we grow older, then the prevalence of diabetes increase. So now let us move to how does Dubai data compare to the Gulf data and the MENA region data. Now, this is, a paper which was published by my colleague, Dr. Khalid Al-Rabi'an, and this is based on a national-wide household population-based cohort of 53,370 participants, and it had involved participants from, from early life, childhood, up to the 100 years of age, using the fasting blood glucose to screen for impaired fasting and also diabetes. What they found that for children who are under the age of 6 years, the prevalence of impaired fasting was found to be 2.8%. For those age group 17 to 18, the impaired fasting glucose was 6.4%. And for those age group between 19 to 24 years, the impaired fasting glucose was 6.7%. So that makes the overall prevalence of pre-diabetes for all age group in the Kingdom of Saudi Arabia 22.6%, and specifically for those above the age of 30, the pre-diabetes prevalence is 25%. Now, how about the prevalence of pre-diabetes in Dubai versus Kuwait? As you can see, among Dubai UAE national, the prevalence was 18.5%, which is more or less the same as in Kuwait, which is 19.4%, and that of Oman, which is 11.8%. Now, let us move to the let us move to the east now, and this is the data which had been published. This is based on National Diabetes Survey of Pakistan, year 2016, 2017. It was a huge number of people who were screened, more than 10,000, and they were divided in 3,729 from urban areas and 7,000 from the rural area. And what they found that the prevalence of pre-diabetes was 14.4%, which exactly match the prevalence of diabetes among in the Emirates of Dubai. Now, if we move to the heart of the MENA region, here in the Alexandria. This is another, cross-sectional study which was conducted on a representative sample which involved 9,657 age group 18 to 19 years of age, and using the fasting blood glucose after an oral glucose load. And they found that the prevalence of diabetes, which is the blue bar among Alexandria, which more or less represent Egypt, 14.6%, which more or less also match the data that we found among our expats in the Emirates of Dubai, which is 15.8%. Now, this is another, publication by Professor Mohammed Tom, and this is the increased preference of type 2 diabetes mellitus and impact on ethnicity, and this came from the North Sudan data, which was a cross-sectional population in North State and River Island State using random multi-stage cluster sampling of almost 5,000 participants, and it covered 60 urban and 40 rural cluster. It shows that the prevalence of pre-diabetes was almost 13%. And if it was compared, because of different ethnicity who, are residents of the North Sudan, for example, in those who are Asian descent, the prevalence of pre-diabetes was 16.4%. Now, looking again into the same data of the North Sudan, which was not far away from our data in Dubai as well. And, as we all know, as we grow older, we put more on weight and we have increase in waist circumference, then we have more risk of developing of pre-diabetes. So if we look back to this data of North Sudan, and you see those above the age of 60, they have a prevalence of 17% compared to those age group 18 to 39, which is 7.1%. Similar thing, the BMI in those who are, morbidly obese is 15% versus those normal 11.3%. And if we take the waist circumference and those who have increased waist circumference was 16.9 versus the normal 11.7%. And this is what also we find, as I mentioned, in our Dubai household survey. Now, how about, we move now to the West, and this is, the data from Tunisia, looking at the study which was conducted on a random sample of 6,500 households and age group 35 to 70 years, again using the fasting blood glucose level based on WHO criteria, and they found that the prevalence of impaired glucose was 6%, which is the least among the, MENA region. And this is another data from Morocco, and this is the STEP survey of non-communicable disease, which was carried out between the period between March 2017 till June 2017, and it looked at the population-based study, age group 18, almost 5,429 adults, and the prevalence was more or less the same as the rest of the MENA region, which is 10.4%. So that will take me now to my last three conclusion slide. As you can see now, this is the MENA region. If we move from the west of the MENA region here, we have the prevalence of Tunisia and Algeria, 6%. And if you go to the middle of the MENA region, Egypt, 14.6%. The Kingdom of Saudi Arabia, 22.5%, United Arab Emirates, 18.5%, and if we move then to the east, here in Pakistan, 14.4%. So now I want to ask now this question: how big is the problem? And taking Dubai example, as you can see, and I already, mentioned this earlier in some of my slides, that the prevalence of pre-diabetes in the age group 18 to 35 is 10%. We jump to, double in those age group 36 to 45, and even to threefold in those age group 46 to 60 years of age. So now those who are under the age of 35, in 10 years or 20 years to come, they will be moving from, a low risk group to a high risk group. And here, we have to just, stand and think about this, that the magnitude is quite big if we did not do, or if we did not, act upon, to stop and halt the rate of conversion from pre-diabetes to diabetes. And that takes me to my conclusion slide, that the prevalence of pre-diabetes in the MENA varies from 6 to 22%, as you have seen from different regions. And the data of many countries, such as in Egypt, Gulf countries, and Pakistan, are alarming figure. And the prevalence of pre-diabetes is strongly related to age, obesity, and physical activity. So we really require an urgent structure plan that can address the large scale of the problem, as well as overdue to halt the progression of the serious health problem and development of the diabetes. And with this, I would like to thank you all for your attention, and I take the opportunity from this platform to say we have to put hands in hand, and we should have the wake-up call to diabetes, and we act immediately. Thank you very much for your attention.
Is to spread health awareness to minimize diabetes prevalence. Now, our third speaker, Professor Inas Shalkout, will provide us with important lifestyle and pharmacotherapy recommendation for reducing the increase in diabetes in Africa. It's my pleasure to welcome Professor Inas, Professor of Internal Medicine, Diabetes, Cairo University, President of the Arabic Association for the Study of Diabetes and Metabolism, ESD, during working as lecturer, a professor of internal medicine and diabetes, Faculty of Medicine, Cairo University, has supervised over 35 MD and MSc theses, has done several published research in the field of internal medicine. Professor Inas, the floor is yours.
Thank you very much, Professor Sanjeev, and thank you for the MENA region for allowing me to give this lecture. I'm going to talk about diabetes prevention, the role of lifestyle and pharmacotherapy. And let me start with the 9th edition of the IDF Atlas, published in 2019, and it said that 1 in each 13 adults is having impaired glucose tolerance, with a total of 374 million persons with pre-diabetes, and this gives an extra 22 million adults having the risk of developing diabetes between 2017 and 2019. During the past 20 years, major socio-demographic changes have occurred. Life expectancy has improved dramatically, urbanization and per capita income has increased. The changes in physical activity and dietary patterns have promoted the development of diabetes, inactivity, and high energy diet. Is diabetes preventable? Yes, there is a good evidence that diabetes can be prevented, and the burden of disease and cost to the economy are significant drivers to action. According to the International Diabetes Federation, there is no effective intervention existing to prevent type 1 diabetes, but we focus on factors identified for the prevention of type 2 diabetes. And there are risk factors which are either non-modifiable or modifiable risk factors for the occurrence of type 2 diabetes, and the non-modifiable risk factors include ethnicity, genetics, and age, and modifiable risk factors are diet, adiposity, physical activity, and environmental exposures. Health education is proportional, the level of health education is proportional to the degree of diabetes prevention. This is noted, and again, There is uncontrollable risk factors and controllable risk factors. And among the risk factors which are uncontrollable, education can have an effect on overweight, on habitual physical inactivity, on pre-diabetes condition like impaired glucose tolerance or impaired fasting glycemia, history of gestational diabetes or big baby. And hypertension may be also improved by education about lifestyle and exercise. HDL and triglycerides, dyslipidemia can be improved by health education. Polycystic ovary syndrome and history of vascular disease all can be modified by health education. Preventing diabetes, the IDF recommends physical activity at least 3 to 5 days a week with a minimum of 30 to 45 minutes. And also the WHO developed recommendation on physical activity for different age groups. For the IDF recommendation for a healthy diet for general population, for drinking, they recommend choosing water, coffee, or tea instead of fruit juice, soda, or other sugar-sweetened beverages, and eating at least 3 servings of vegetables every day, including green leafy vegetables, eating up to 3 servings of fresh fruit every day, choosing nuts, a piece of fresh fruit or unsweetened yogurt for a snack, limiting alcohol intake, and choosing lean cuts of white meat, poultry, seafood instead of red or processed meat, and choosing peanut butter instead of chocolate spread or jam, and a whole grain bread, brown rice, or whole grain pasta is better instead of white bread, rice, or pasta. And to choose unsaturated fats, for example, olive oil, canola oil, corn oil, or sunflower oil, instead of saturated fat like butter, animal fat, coconut oil, or palm oil. I screened the IDF recommendation for diet for general population. We come now to the WHO recommendations on physical activity for different age groups. For children and youth between 5 and 17 years, we should do at least 60 minutes of moderate to vigorous intensity physical activity daily. And for those between 18 and 64 years, they do at least 150 minutes of moderate intensity aerobic physical activity like brisk walking, jogging, gardening throughout the week, and at least 75 minutes of vigorous intensity aerobic physical activity throughout the week, or a combination of both moderate and vigorous intensity activity. For older adults, the same amount of time for physical activity is recommended, but should also include balance and muscle strengthening activity according to their ability and circumstances. And to prevent diabetes, dietary recommendations of the WHO for prevention of type 2 diabetes include limiting saturated fatty acids intake to less than 10% of the total energy intake, and for high-risk patients, less than 10%, and to achieve adequate intake of dietary fiber, minimum 20 grams of fiber daily in the form of whole grain cereals, legumes, fruits, and vegetables. And the WHO strongly recommends reducing the intake of free sugars to less than 10% of the total energy intake daily. The American Diabetes Association in 2020 recommends obesity management, which can delay progression from pre-diabetes to type 2 diabetes, and it may be beneficial even for the treatment of type 2 diabetes. Again, the ADA, for patients with pre-diabetes, they should be referred to intensive behavior lifestyle intervention program, model like that of diabetes prevention program, And the main objective is to achieve and maintain 7% loss of the initial body weight and to increase the moderate intensity physical activity at least 150 minutes per week. Metformin is recommended for the American Diabetes Association, and it has demonstrated long-term safety as pharmacotherapy for diabetes prevention. And in addition to metformin, the alpha-glucosidase inhibitor, orlistat, glucagon-like peptide 1 receptor agonist, and thiazolidine have shown a beneficial effect in reduction of pre-diabetes, shifting to diabetes to various degrees. The pharmacological intervention according to the ADA, which is metformin therapy. The metformin therapy is highly recommended for people with body mass index more than 35 and women with prior gestational diabetes mellitus for prevention of type 2 diabetes, but long-term use of metformin may be associated with vitamin B12 deficiency. So it is recommended to measure vitamin B12 level, especially in those with long metformin use or anemia or peripheral neuropathy, and maybe supplementation of vitamin B12 in case of deficiency. Diabetes is a preventable disease, and the proven methods in prevention are lifestyle modification, drug use, and further future methods in the form of vaccines or genetic, maybe, but not yet approved. And we come now to different trials done on diabetes prevention, and let me start with the Finnish study, 2010, and the number of cases were about 500 cases, and the mean age was 55 years with body mass index mean of 31 kilogram per meter square, and those cases were having impaired glucose tolerance, and there was two groups, a control group and intervention group. The control group received brief dieting and exercise counseling, while the intervention group received intensive individualized instruction to weight reduction, food intake, and physical activity guidance. And the duration of the Finnish study was 3.2 years. And there was reduction of 58% of cases of type 2 diabetes with just lifestyle modification in the Finnish study. Another famous trial, the Stop Non-Insulin Diabetes Mellitus trial, with a number of cases of 1,429 cases, mean age of 55 years old, with body mass index 31, and all cases had impaired glucose tolerance. There was two groups. The placebo group received placebo, and the tested group received acarbose, alpha-glucosidase inhibitor, and the duration was 3.3 years, and the result was reduction in new cases of diabetes among those with impaired glucose tolerance in 25 to 36% of cases. The diabetes prevention program, another mega trial done on 3,234 cases with impaired glucose tolerance and the body mass index mean of 34 kilogram, and the mean age was 51, and the duration of the trial was 2.8 years. And there was two groups. One group, which was a lifestyle group for intensive nutrition and exercise counseling, and the other group, there was two medications, either biguanide, metformin, and the other group was placebo. And the lifestyle showed 58% reduction of new cases of type 2 diabetes, while the metformin showed 31% reduction of new cases of type 2 diabetes. And there was 31 risk reduction of progression to type 2 diabetes with the use of lifestyle intervention and metformin. They both had positive effects on prevention of type 2 diabetes and restoring normal glucose tolerance. And the recommendation of diabetes prevention program was to do lifestyle intervention and also to give metformin as drug therapy for patients with impaired fasting glycemia or impaired glucose tolerance. The diabetes prevention program outcome trial for those patients in the diabetes prevention program, but for the following 10 years follow-up. And this was the patient and methods. The number of cases were more than 3,000 cases. And the results showed the diabetes incidence 10 years since the diabetes prevention program was reduced by 18% in cases of metformin group and 34% in lifestyle group. This proved the superiority of lifestyle modification in the prevention of type 2 diabetes. And the recommendation again was to give metformin therapy to prevent or delay the conversion of pre-diabetes to type 2 diabetes in high-risk individuals. And effective lifestyle intervention again is very crucial to prevention of type 2 diabetes in pre-diabetic. We come now to another trial published by Diabetes UK about the use of different oral anti-diabetic medications, and the conclusion of this trial showed that of the oral anti-diabetic drugs evaluated, there was thiazolidinediones, and it was associated with a greater risk reduction compared to the control, and it was associated with greater risk reduction than even biguanide and alpha-glucosidase inhibitors, and the results were better than any other sulfonylurea or grenade used during this trial. And let me finish with this interesting observation. This observation is about the SGLT2 inhibitors started during the heart failure trial, the DAPA heart failure trial. And during the DAPA heart failure trial, 58% of the patients had diabetes already, and the remaining cases were not diabetics. But dapagliflozin showed 32% of the patients were less likely to progress from pre-diabetes to diabetes during the course of the study. So this is the first knowledge that SGLT2 inhibitor trials showing potential diabetes prevention. Is that going to affect the future for these medications, SGLT2 inhibitors, or particularly dapagliflozin, or not? Prevention, early identification, and effective interventions are integral components of effective type 2 diabetes care, and these strategies may reduce the expanding economic burden associated with type 2 diabetes care. Thank you. Shukran lahada.
Okay. Thank you, Professor Unis, for your important lecture and nice information. In light of this emerging pandemic COVID-19, Professor Hamdi will show us his experience in Joslin Clinic and aspirations for the future, funding a new ways in telemedicine to deal with diabetes. But the question is, can we apply the telemedicine in our region? So we move to the last speaker, Professor Hamdi. It's my pleasure to present him. He is senior endocrinologist, medical director of Obesity Clinical Program, director of Inpatient Diabetes Program, Joslin Diabetes Center. He is associate professor of medicine at Harvard Medical School. The title of his presentation, Prevention of Diabetes, a Look into the Future. Professor Hamdi, the floor is yours.
Thank you very much, and it is an honor and pleasure to be invited to this elegant symposium in the Middle East. I usually love to speak to the area where I grew up in and share with them some of the information that we already have here and exchange knowledge. And I enjoyed, in reality, all the presentation that had been presented so far. And I would like to let you all know that this presentation, I believe, will be interesting to a lot of you because we are looking not on what we are doing right now, but how the future will look like. And many of that changes that we are expecting in the future already started in the last, I would say, 4 or 5 years. So, as Dr. Adil mentioned, the problem with diabetes and pre-diabetes is growing significantly. If you just take a glimpse in the United States, 29 million already have type 2 diabetes. And one of every 4 don't know that or doesn't know that he or she has diabetes. Interestingly, 1/3 of the whole U.S. population now have pre-diabetes. Unfortunately, around 9 out of 10 don't know that they have pre-diabetes. Dr. Fathi Al-Awadi mentioned also scary figures about pre-diabetes and diabetes in MENA region. So we know that the problem is all related to obesity. Just to let you know that every 1 kilogram of excess body weight increases the risk for diabetes by around 9%. So you can imagine when people start to gain significant weight, how the prevalence of diabetes and pre-diabetes will be, how high it is. You know, interestingly, in the late 90s, we did one study at Joslin measuring what's called endothelial function, which is a very early stage of atherosclerosis. And we measured endothelial function in people with diabetes and people with pre-diabetes, and even in people with just a family history of type 2 diabetes. And we were shocked to find that the same level of endothelial dysfunction and the same risk of cardiovascular is equal in the 3 groups, which means that it is a continuum of risk. We just put a line to define people with pre-diabetes or diabetes, but the reality is that it is a continuum risk for cardiovascular disease. Definitely weight loss is a key. And this is back to one study that we did in the beginning of the century. And the study was done among patients with diabetes and pre-diabetes and just obese individuals with insulin resistance. And we found that when people lose 7%, just 7% of their body weight, insulin sensitivity improves by 57%. This is huge. I was shocked when we saw this data because this means that you can reverse diabetes, you can prevent diabetes. And this study was a foundation of the entire concept that 7% weight loss is very important in people with pre-diabetes and diabetes. Then came the diabetes prevention program. Dr. Ines kindly reviewed the diabetes prevention program. I was one of the investigators in the diabetes prevention program. And we found nicely, as Dr. Shaltut mentioned, that you can reduce conversion to type 2 diabetes by lifestyle intervention by around 58%, and with metformin around 31%. So definitely there is superiority in the lifestyle. But the question remains how you can implement it in a bigger scale. You can do it in a clinic, you can do it in a diabetes center, but how you would do it to the public? We are talking about significant number, say 1/3 of the US population, for example, have pre-diabetes. Around 6 to 22 in the Middle East has pre-diabetes, and I think maybe even more in the future. So how you will build this into the mass? So in last year, I wrote an article in Cell Metabolism, which is one of the major journals, and the title was very interesting: Patient-Driven Diabetes Care of the Future in the Technology Era. More than 500,000 downloads of this article now, because the article is opening the eye how the future and how the technology will change what we do and what we shall do. And I believe during the COVID-19 era, every one of us started to have hands-on many of those tools. And the future is telling us that artificial intelligence, for example, will be one of the very effective tools. So just to look for the literatures that have been published in artificial intelligence and diabetes, and you see how much they are going right now. It is huge jump, more than 10,000 articles in a year around artificial intelligence in diabetes. But on the basics of technology is what's called digital health. So what is digital health? Digital health is the use of telemedicine. And telemedicine is basically you'll be able to provide the care in a remote technology using audio-visual technology, similar to what we are doing now in this webinar. You communicate with your patients through the web or through the app. The other method is mobile health. And mobile health is very interesting because a lot of people now have a smartphone, more than people who are still using non-smartphone. You can send a text. You can have an application that communicate provider and patient. And also you can do blood glucose monitoring and transfer this information. But it takes a lot of technology to integrate all of those together. So for example, let me show you our latest model that we developed at Joslin Diabetes Center. It's called Joslin Home. And we developed this model almost 2 years ago, ahead of COVID-19. We didn't know that COVID-19 will come in, but we were well prepared. So the idea is to send the clinic, the diabetes clinic, to the patient home. Basically a box that has a glucose meter attached to the cloud, blood pressure meter and scale, and then communicate with the patient by a multidisciplinary team, includes exercise physiologists, dietitian, behavior therapists, physicians, nurse practitioner, and educators. And we created 5 new pillars of the care: short visits, multiple visits, easy appointments, easy cancellation, or remote. There is no overhead cost at all, zero overhead cost, and precise documentation. And in the same time, the billing was so simple and easy and straightforward. And it worked very well. We presented the data at the American Diabetes Association this year. But in a simple way, patient in the middle, everyone is around them. On the patient phone, they have all his or her team, and people can swipe and can change anyone, and can see a dietitian maybe in California, exercise physiologist in Seattle, and maybe educator in New York. But it breaks all the barriers of distance and the location. And it worked actually very, very well. We have very good results. And physicians were able to complete their mission in an average of 11 minutes. It worked very well. A1C went nicely in people with diabetes. We didn't try it yet in pre-diabetes, but you can see very, very simple that you build your own team, and that team you can use them and communicate with them in a very simple and easy way. You can even communicate with them if they are available immediately at your time. Now, moving to digital intervention for the pre-diabetes. This is a major issue because you are now working on a mass. So, for example, when Dr. Fathia Al-Awadi was just mentioning is between 22.5 and 25% of the population have pre-diabetes. You need something that work on the big mass. Usually what people ask at the beginning, is this cost effective or not? So diabetes prevention program, which Dr. Ines mentioned, had been implemented in the United States for several years now using digital technology, and many health economic studies have been done to show if this is cost effective or not. And in reality, they found there is huge saving. So here is the projection of the saving, and you can see saving on pre-diabetes in 5 years, it will be around $1,500 per year. And 5-year reduction in diabetes was around 30 to 33% using digital technology. This saves a lot of money. Spend on diabetes in the United States around $237 billion. So you can imagine saving by reduction and conversion of diabetes in 5 years by that much. Also, market reduction in cardiovascular risk and big saving and reduction in a stroke by around 11 to 16%, and saving in 5 years of $1,500 per year. So any money that is spent on diabetes prevention will pay off, and will pay off generously, especially beyond the second year, as you can see, after you cover your cost. For this reason, the United States government decided that for Medicare patients who are covered by the government, this program will be available for everyone, and they will pay around maybe $700 to $900 for this program for every single patient. Insurance companies start to follow the same. They are paying now for the program. So, but how to design an effective weight management program? Because as you all know, when we started the diabetes prevention program, we don't have all the knowledge that we have right now. So the diabetes prevention program was a little bit primitive at the beginning. It was just 150 minutes of activity and hypocaloric and low-fat diet and high fiber, as Dr. Sheltut mentioned. But again, we know now that this is not the most effective model. Because if you need to build an effective weight management program and you aim in that scenario between 5 to 10% weight loss, and I would say the golden number is around 7%. But even in the diabetes prevention program, we found that even 3% weight loss can prevent diabetes. So even as minimum as 3% weight loss can do that. But if you reach 5 to 7%, is definitely very effective. If you reach 10%, maybe you can reverse the situation in many other associated comorbidity like hypertension and dyslipidemia and many other mechanical problems. But how to do it? How to implement an efficient nutrition plan? We have now what's called the structured nutrition plan, which is the American Diabetes Association recommendation starting from 2019. How to do an exercise program, because you need an optimal exercise program from time, duration, and frequency. There is a model called the cognitive behavior modification. Basically, like formatting the brain to get people to change behavior and to be motivated to continue. And then, of course, changing some of the medication that cause weight gain. But the most important, and everyone is looking to this now seriously, how you can maintain it for longer duration. Because if you can maintain it for longer duration, you can definitely be able to maintain the prevention of diabetes. As Dr. Sheltut mentioned, we did the diabetes prevention program outcome study and showed that those people who continue to do lifestyle or continue to use metformin, they have much reduction in the conversion to type 2 diabetes. So at Joslin, we developed the optimal lifestyle intervention programs called Y-Weight program, and we tried to see if we can implement every single aspect of what we learned over years in helping people not only to lose weight, but to maintain weight loss for longer duration. Like For example, I will go to one simple point. People with diabetes lose muscle mass every year. From age 40 and above, people lose around 300 to 450 grams of muscle mass every year. When they go on a low-calorie diet, and you maintain 15-20% protein, people lose muscle mass significantly. And that's why they gain all weight back. So what we try to do here, which is very difficult, is to give people more protein and ask them to do more strength exercise to maintain muscle mass so they can maintain weight loss for longer duration. That's why when we started to see the results of those programs, diabetes prevention program, and the Look Ahead study, which was designed after the diabetes prevention program for people with diabetes, and then YWeight, which was designed for pre-diabetes and also for diabetes, and compare the results at 3-4 years. Diabetes prevention program led to around 4% weight loss in 3 years. Look Ahead study around 5% in 4 years, and YWeight program was around 6.4% in 5 years, not 3 or 4 years in 5 years. So significantly more. I was lucky to be part of the 3 programs, and we know now what is the reason why we be able to achieve better and better results as we improve the model. The most interesting is that last year we presented data in the American Diabetes Association after 10 years. So after 10 years, people are still maintaining 6.9% weight loss, which means that if this is done for people with pre-diabetes, you can maintain the reduction in conversion significantly down. As I mentioned, 7% is the key. And when we started the diabetes prevention program, that's what our aim is, to help them to lose 7% and maintain that weight loss. So now, from that time, around 28,000, you see how the number is big, 28,000 weight management program smartphone application exist. Interestingly, most applications only incorporate around 19% of the behavior strategy that we bought in the diabetes prevention program, in the Look Ahead study, and in YWeight program. So now apps in the future will benefit significantly from artificial intelligence, decision-making support. That is very, very important. Coaching and motivational support beyond the limit that we had in the diabetes prevention program, but also stress reduction features. Motivate people, leave their anxiety and stress, and help them to maintain weight loss. So there is a big potential that many of the evidence-based program be implemented in a smartphone. So one of the biggest challenge for us, for example, is how to lead people do strength exercise. Because people can injure themselves, they cannot do it, they usually need a personal trainer. If it is just walking, it was to be so easy, but to add strength exercise was a big and important factor that lead people to maintain weight loss for longer duration. So another technology came, and that technology using avatars. So you take the exercise physiologist, you put sensors in their body, and they can do the activity, and then the avatar on the phone will show you how to do this activity and repeat it and time it for you. And in that way, they were able to develop programs that can motivate people. Every day they go on a track, enjoy doing the activity, give them the task that they need to go through during the day, from eating to exercise to snacks, show them how to do the exercise and time the exercise and the type of exercise, give them all the behavior tips, and they can see a TV and discussion with dietitian, exercise physiologist, and the most important, to reward them. Every time they do some achievement, you reward them. And then you coach them, and you create groups that can communicate. People love now social media, and they love interaction, and they love that community support. And it worked very well. And you can connect all the devices now in one app. You can connect the glucometers, you can connect the blood pressure, you can connect all the kind of tools. You can have it on the on a watch. You can reward the people when they do very good job. And then send the people to their home all the tools that they need: scale, stretch bands, kitchen scale, even fitness tracker like Fitbit or similar, and try to help the people by all means. Now, several companies in the United States are doing the box now and sending the box to patient home to be in the program, and then start to monitor them and coach them and help them. More advanced is to connect all this information to electronic health record. For example, EPIC, you can connect and you can immediately see how the progress in weight loss, how the progress in exercise. Even by artificial intelligence, it can create a report card indicating how much patient progress, what to have to tell your patients, even encourage your patient to follow diet, congratulate your patient on activity. The adherence, it measures the adherence. It is just in 60 seconds, you can get all this information. Any lab results before, any lab results about how patients are achieving target, how compliance are. So it makes life very easy. And you can beam all this information directly to the system. Just a few weeks ago, we finished the first virtual Y-Weight program where a multidisciplinary approach occurred. And interestingly, people lost a very, very good amount of weight. You can see week after week, they keep losing weight. They lost by the end of 12 weeks around 14 pounds, which is almost around 6-7 kilograms and around 7% of their body weight. That achievement is very interesting because now you have a tool that you can give it to millions of people and coaching them, and they can achieve very, very, very nice weight loss. People who even have diabetes, who implemented that, they see around 0.8% drop in their A1C, and many of them stopped their medication. Moving to the future with CGM, you connect the CGM and you overlay on the CGM all the meals and all the activity, and you can give patient a way to learn from their numbers, see best days, get reward when they do good activity, and then you can see how the meals looks like, how the calories looks like, how the exercise looks like. A lot of information that patient can see and change their behavior significantly. And again, you can reward them if their blood sugar is very good. You can motivate them all the time, and so on. So it is very, very important that we can now, in 2020, have a very cost-effective digital intervention. Definitely, it reduces the patient commute and wait time, because patient can do it from their home, from their work, from anywhere. It reduces loss of productivity at work. You know that diabetes and pre-diabetes has a lot of indirect costs related to absence from job. Also, you reduce the time spent at the physician on visits. So all digital communication can make it life easier with patient in their place. And then, as you have seen, there is a better or even equal results, equal or better than the usual outpatient care. And then, so far, it has been very clear that patient and physician satisfaction is very, very high. Moving quickly now to the future, and many companies are working now to develop a whole ecosystem. So the whole ecosystem through the smartphone, you can have the telemedicine visits, you can get your prescription from the pharmacy automatic, you can have the food and exercise logging, you can get education that you need, you can monitor blood glucose or blood pressure, you can monitor weight, you can track all this information, you can communicate with patient, and then you can give them a forum that they can interact with each other. Ecosystem is very, very good because it takes patients all over there 24 hours in a journey. And in that journey, they are connected and communicated, even with restaurants, with gymnasium. When you enter a grocery store, it will direct you to the healthy food and give you information by scanning the food. And in the same time, in restaurants, will give you option for menus. You can order through the phone, the healthy choices, you get discounts. Gymnasium, you get membership, or you can go and as you go to do some exercises. There is a lot of option and a lot of ideas. I know there are several states now starting to implement statewide that whole concept. So the future is very interesting, and the care will be given to our patients where they are. There is no limitation where the physician is. There is no limitation where the patient is, and what is their condition. So the take-home message from this quick presentation is that successful diabetes prevention program can be implemented through telehealth and mobile health. We know that this can be done and can be done in a very effective way. Chosen home model, for example, is an innovative, scalable model for diabetes care using digital health. This is a continuation from pre-diabetes to diabetes. Educational support can be achieved through remote coaching and telemonitoring of our patients. Definitely, there is a cost effectiveness and saving. They found the saving on total healthcare cost is around 27%. The saving on diabetes-related cost and pre-diabetes-related cost is around 44%. Again, it is accessible to patients where they are. And that's the beauty of the technology, that you can access people where they are and be effective as they are coming to the clinic. With that, I would like to thank you all, and I'll be more than happy to entertain any question that you come in the discussion section. Thank you very much, and we'll be with you with the panel for discussion.
Okay, assalamu alaikum everyone. I think we can start with the faculty for the moderation of the questions and answers until Dr. Sandeep can take over. Perhaps all the speakers can open their cameras and their mics so that we can have the discussion with the Q&A. So until we go through the questions and answers, first let me ask Dr. Adil a question regarding the link to the cardiovascular risk of prediabetes. So Dr. Adil, what are your thoughts on what's happening here? Do you think that the prevention of cardiovascular problems in prediabetes stage, in diabetes stage, should apply also to prediabetes? So should a person with prediabetes, for example, be on aspirin, on statin, on SGL2 or GLP-1, or we should simply treat the prediabetes and deal with the other risk factors accordingly?
Well, thank you, Dr. Muhammad. This is an interesting question, actually. And the problem is we do not have data enough to form a sort of formal recommendation regarding the issue. Up till now, all we know is that the risk is not very high, as that of diabetes. That's number one. Number two, we do not have solid data regarding the different methods of treating these complications. So I believe that the data now is you have to reduce weight, you have to change lifestyle, and if necessary, you can add metformin, especially on those young obese individuals, because that was the area where metformin was best effective in the diabetes prevention program in young obese individuals. So in these cases, you can add metformin, but otherwise adding drugs, I do not think is a wise policy, as far as we do not have straightforward evidence, and of course regarding the issue of the cost, because most of these GLP-1 and SGLT2 are expensive drugs, and we have to use them whenever it is strictly necessary and strictly indicated.
Okay, thank you, Dr. Adil. There's a question to Dr. Fathia. People asking about the feasibility of doing a MENA region study on prediabetes. How feasible this do you think is?
Okay, I was just saying that thank you very much, Mohammed, for this question. But as you are aware, most of the the data of diabetes or pre-diabetes come out of a screening program within the individual country. If we have a study, it will be I think technically difficult. But what we would like to encourage, as I just mentioned earlier, that each country maybe they need to to publish more data related to diabetes and pre-diabetes as well. I do know that there's many publications in the field of diabetes, and also it's not easy to do these mass screening across the region, because it requires manpower. It also requires it requires lots of infrastructure. It also requires and it is also of a cost. I don't know what is the view of other colleagues there, but we are welcoming any research that we can do collectively together. That will be very good, which will be very helpful to our region. And I mean, if anything can be commented from my colleague, I'll be more than happy also to have the feedback from other speakers as well.
Okay, thank you, Fathia. Professor Ines Shaltut, there is a question for you. Some are asking about the best drugs for prevention of diabetes, and others are asking about metformin for the overweight and those who are over 60. So, in your mind and from your practice, what would be the best drug to use for pre-diabetes? And specifically, what about the role of metformin for those who are overweight or over 60 years of age?
For those with pre-diabetes, the only preferred drug is the metformin, and there is no contraindication above the age of 60 except if this patient is having some renal or hepatic impairment. If not, then we can start with metformin. Some questions are coming about what's after metformin. We don't have any confirmed or approved medication after metformin, but the AGA said that some other medications are beneficial, giving benefit. If the patient's blood glucose is still high after metformin, maybe this patient is already a diabetic patient. So we have to think of that. If metformin with a full dose of 2 grams per day is not enough to control the pre-diabetes, then maybe this patient is converted into diabetic patient, and then we can use any other anti-diabetic medication. And the recommended medications by the AGA, which have benefits, but they are not approved yet, are alpha-glucosidase inhibitor, thiazolidinediones, GLP-1 receptor agonist, and orlistat. They are suggestions, but are not approved now. For those having cardiovascular risk factor or cardiovascular disease, or at high risk of atherosclerotic cardiovascular disease, we may think of SGLT2 inhibitors, but these all need to be approved by some guidelines or the FDA, which didn't till now confirm any medication for pre-diabetes.
Okay, thank you very much, Professor Ines. So, Professor Hamdi, you have showed elegantly how can the technology help. With the large numbers of pre-diabetes in the region, do you think pre-diabetes must be tackled with a technology tool, or can it be tackled on a face-to-face basis every day in our clinics?
Yeah, this is a very good point, Dr. Hassanin. Definitely, you cannot handle this by face-to-face. You know, clinics are overloaded with patients with diabetes, and people with pre-diabetes double or triple that number. So there is no way except the technology. And if the technology proved right now to be very effective, why not to be implemented? You know, in the United States, we have been using technology for prevention of diabetes for almost 6 years. The results are amazing. Saving is huge. Insurance are doing. But in the MENA region, it is still difficult because there is, in my personal opinion, there is no seriousness up till now in tackling this problem, and we have some inertia to start. And I will encourage that we don't waste too much time. It is like a patient bleeding and continue to bleed, and we keep diagnosing that that person is bleeding, but we are not taking any action to stop that bleeding of money, bleeding of health. So many countries now already are far in the prevention of diabetes. They showed very good response, and technology is advancing quickly. So the tool that we are using in 2020 is way better than the tool that we had been using 4 or 5 or 6 years ago. And you can see that this can be done in a very efficient way, especially that bandwidth is better, smartphones are available, and coaching can be very simple and effective.
Okay, stay with me, Osama. There is another question for you that perhaps you can answer, or any of the other colleagues. Someone is asking, if a patient with pre-diabetes is found to have retinopathy, will he be labeled? I mean, in the States, you use the coding. What would be the code for this person, or the diagnosis of this person? Pre-diabetic with retinopathy, or diabetic with retinopathy, or what exactly?
Yeah, that's a very good point. As I mentioned, it is a continuum of problem. So, for example, if you look at time of diagnosis for people with type 2 diabetes, already 19% of them have retinopathy. Some early, and some of them even advanced a little bit more. But 19% at the time of diagnosis, which means that we are up till now taking an arbitrary number that we diagnose diabetes. Mind that the 7% number and the 6.5% number came from the studies done on type 1 diabetes, not on type 2 diabetes. So in my personal opinion, we have to remove that number entirely and consider pre-diabetes and diabetes as one continuum. Because the risk for cardiovascular disease is the same. Risk for macrovascular disease can be also similar to aggressive cancer. It becomes even more serious when they develop diabetes. But from the time that someone has family history of diabetes and start to gain weight, that's when the action needs to start.
About the debate between cardiologists and endocrinologists or diabetologists, whether we can still keep Metformin as the common drug for all diabetic patients, and then adding SGLT2. My question is, what the place of SGLT2 in pre-diabetes? It is a first choice before Metformin or not?
Comment on that.
Are you hearing me?
Can I comment on that, Mohammed?
Yes, of course.
Yeah, thank you. No, of course, SGLT2 are not recommended now for treatment of pre-diabetes. No studies are there regarding that. And Metformin has been well studied. There is one thing about Metformin, maybe I would like to clarify, that the Diabetes Prevention Program, when they broke down the results, they found that not all patients did the same regarding the results, the preventing results of Metformin. As I said, young and obese individuals were almost as effective as lifestyle, but in old and slim individuals, the prevention results were very modest. And because of that, we have to know how to choose our patients for prevention by using drugs. If we are using metformin, which is, well, the most approved one, you have to choose your patients among young and obese individuals. It's not because it will be harmful to older patients, but because it will be less effective in older and slim individuals. This is the issue. But for GLP-1 and SGLT2, I do not think that now we are in the era of comparing these drugs with metformin regarding prevention of diabetes, of course, because they are very expensive and because they are not very well studied, just like metformin. So this is my opinion regarding that.
Okay. So I would like to thank Professor Hamdi for your very valuable lecture. We regret this delay in the program due to a technical error. Unfortunately, it left a lot of attendees. Therefore, we will shorten the question and suggest sending the question by email. Donc, finally, I want to thank all the lecturers, Professor Sayed, Professor Al-Awadi, Professor Inas, Professor Hamd, for their valuable information. And thanks to everyone that attended, and thanks to Merck to the support this webinar and organizer. I will announce to you that there will be a webinar on September 4. I think this is all information. Thank you. Stay safe.